Today, I want to talk with you about stroke. Stroke is the fourth leading cause of death in the United States, and it's the number one cause of long-term disability in adults. About 795,000 new cases or recurrent cases are reported yearly. Stroke may be classified as number one, ischemic, which is the absence of blood supply to the neurons and accounts for 87%. Secondly, hemorrhagic, which is a bleed in the brain parenchyma and accounts for 10%. And thirdly, subarachnoid, which is really not a classification, but it falls on the hemorrhagic, and this occurs when there is bleeding in the subarachnoid space, and it accounts for 3%. Emergency providers such as MDs, DOs, NPs, and PAs play a significant role in the lives of the stroke patients and should know how to do the following. Number one, a workup. Number two, the management. And number three, determine proper disposition of acute stroke patients. Now, here's a schematic of the outlay of stroke. Stroke, again, as I said before, can be classified as ischemic or hemorrhagic. Ischemic can further be broken down into embolic stroke, which accounts for 40%, and thrombotic stroke, which account for 60%. Hemorrhagic stroke, as I said before, is a bleed in the brain parenchyma, and subarachnoid is a bleed in the subarachnoid space. The problem with subarachnoid is that it can result in vasospasm and subsequently cause more ischemia in the affected area. Normally, embolic stroke has a cardiac origin, while thrombotic stroke is due to atherosclerosis. Air, fat, and amniotic fluid may also cause embolic stroke through atrial septal defect. Once there is arterial occlusion, there will be hypoperfusion. This will result in a localized area of the brain being deprived of oxygen and glucose, and irreversible damage to the neurons begins within minutes. The common presenting symptoms. How do these patients with stroke present? Patients may present with numbness or weakness of the face or the arms or the legs. Other patients may present with trouble seeing in one or both eyes. Patients may present with confusion or trouble speaking or understanding. And some patients may have difficulty walking with associated dizziness or loss of balance and coordination. Or a patient may present with a combination of these symptoms. The risk factors for stroke in adults. The most important risk factors are age and hypertension. Number two, smoking. Number three, diabetes. Number four, hyperlipidemia. Number five, atrial fibrillation. Number six, coronary artery disease. Number seven, family history of stroke. Number eight, previous stroke. And number nine, carotid bruits. Risk factors in young people. Young people are also predisposed to strokes. It's not a common occurrence, but there are cases that do occur. One of the risk factors that one has to consider is oral contraceptives, and that is in females. Secondly, you have to think about hypercoagulable state, such as protein C and protein S deficiencies. Number 3, you have to think about vasoconstriction as a result of drug induction, particularly cocaine and amphetamines. Number 4, polycythemia vera. And number 5, sickle cell disease. The next thing I want to know is the history. Getting a good history is critical to management and outcome. Try to obtain accurate information from EMS, family, or friends. The first thing I want to know is the time of onset of the patient's symptoms. This time is based on the last time the patient was seen in wellness. Other aspects of the history include the risk factors. Does the patient have any risk factors? The physical examination. The physical examination will be positive for the neurologic deficits that brought the patient to the emergency room. If the patient's symptoms begin to improve without treatment, it is less likely to be a stroke and more likely to be a TIA. Next, let's talk about the diagnosis and the workup. For the patient who comes to the emergency room with suspected stroke, there are certain things that should be done. First, ABCs should be checked. Next, you should obtain vital signs and repeat the vitals every 15 minutes. Then, provide oxygen if the saturation is less than 92%. Place an IV line and order labs. Check the glucose level. If it's less than 60, then provide 1 amp of D50. Do not treat elevated blood pressure prior to obtaining a head CT. Order a non-contrast head CT, and this should be done within 25 minutes of arrival to the emergency department. The report should be given within 20 minutes of completion of the test. Therefore, arrival to interpretation should be 45 minutes. Perform an EKG and place the patient on cardiac monitor with pulse oximeter. And if the head CAT scan is negative, thrombolytics should be started within 3 hours of onset of symptoms. Now let's talk about the inclusion criteria to administer TPA or thrombolytics. Number 1, there should be ischemic stroke with clearly defined time of onset. Number 2, there should be neurologic deficits that can be clearly measured. And number 3, there should be a baseline head CAT scan with no evidence of intracranial bleed. These criteria are absolutely important to meet prior to giving TPA to any stroke patient. The exclusion criteria, on the other hand, include the following: greater than 3 hours from symptom onset, rapidly resolving or minor deficit, obtunded or comatose patient, seizure with post-ictal residual neurological impairment, a history of intracranial hemorrhage or bleeding diastasis, ischemic stroke or serious head injury within 3 months, blood pressure elevations persistently greater than 185 systolic or 110 diastolic despite antihypertensive therapy, GU or GI hemorrhage within 21 days, major surgery within 14 days, recent myocardial infarction, arterial puncture at a non-compressible site within 7 days, recent lumbar puncture, pregnancy, heparin administration with elevated PTT greater than 40 seconds, INR greater than 1.7 with a PT greater than 15 seconds, platelet count less than 100,000, glucose less than 50 milligram per dl, and evidence of significant infarction with focal mass effect, hemispheric swelling, hemorrhage, or intracranial tumor. The differential diagnosis of a person who comes in with suspected stroke should include both hypoglycemia and hyperglycemia. Also, one should think about drug overdose. Now, prior to giving TPA, the provider should explain to the patient and or the family the risk factors and the side effects. And these side effects and risk factors include the following. Number 1, cerebral bleed, headache, seizure, and loss of consciousness. Number 2, GI bleed, abdominal pain, and blood in the stool. Number 3, gum bleed and the nose bleed. Number 4, hematuria. Number 5, low blood pressure. And number 6, orolingual edema. Treatment for ischemic stroke. TPA means recombinant tissue plasminogen activator. Altiplase was the first drug approved by the FDA for treatment of ischemic stroke. TPA is a protein that is found on endothelial cells, but not in sufficient concentration to carry out thrombolysis. When it is given intravenously, the drug works by converting plasminogen to plasmin. Plasmin, in turn, breaks up fibrin clots. The ideal blood pressure for this medication to be given is systolic blood pressure below 185 and a diastolic below 110. The dose of IV TPA is 0.9 milligram per kg with a maximum dose of 90 milligrams. 10% of the total dose should be given as a bolus over 1 minute, and the remaining 90% given as an infusion over 60 minutes. Ideally, patients who qualify for TPA should get it within 30 minutes of ER arrival. Let's talk about the post-treatment evaluation. Blood pressure should be recorded every 15 minutes during and after the medication is given for 2 hours. Then every 30 minutes for 6 hours. Then every hour until 24 hours after thrombolytic treatment. Number 2, systolic blood pressure should be maintained below 180 and the diastolic below 105. Number 3, head CAT scan or MRI should be done after 24 hours of treatment. And number 4, the patient should be admitted to the ICU. Let me summarize what I just talked about. Number 1, stroke will either be ischemic or hemorrhagic. Number 2, if stroke symptoms resolve without treatment, it was less likely a stroke and more likely a TIA. Number 3, stroke patients should not be given thrombolytics if their symptoms are beyond 3 hours. However, some stroke centers do give intra-arterial thrombolytics up to 6 hours. Number 4, ideally, Head CAT scan and report should be no more than 45 minutes from arrival. Number 5, blood pressure should not be aggressively lowered in ischemic stroke. Nitroprusside or labetalol may be used. Number 6, always explain risk factors to patients and family prior to giving TPA. And number 7, it is imperative to review the exclusion criteria before giving TPA. Well, thank you for watching, and I wish you well. Good night.